So ladies and gentlemen, good morning. So it's time to open the first session dedicated to laparoscopic surgery with the title Current Trends in Laparoscopic Surgery. So it's my pleasure to co-chair this session with my friend Dr. Kavit Afshi from Turkey.
Javit, no Kavit.
Javit.
Well.
Javit, okay. Sorry. So you have to introduce myself.
Okay. Good morning, everybody. Today, the first day of the Congress and the first session of the first day, I present Dr. Professor Jean-Michel Favre. Yesterday, he's past president of the French Association of Laparoscopic Surgery, coming this night to Bodrum, and you can start. Okay, please. Thank you.
Thank you.
I would like to announce for the question, please. In the hall, we have 4 microphones fixed, 2 here and 2 in the middle. Please, after each presentation, you can take the question coming to microphone fixed. Thank you.
Thank you. So the first talk is about minimal invasive surgery for esophageal surgery. So we know that the last TNM classification clearly demonstrates that the place of surgeries is indicated when the tumor is more than T1B, because in that case,
Jean-Michel, to speak to microphone, please, okay. Because we have the registration.
When the tumor is more than T1B, the incidence of lymph node involvement is more than 30%, between 30 to 60%. Another very critical point is that the last classification considers that cervical and celiac lymph nodes are not considered as contraindication of surgery because they are not metastatic disease. Only retroperitoneal and supraclavicular lymph nodes are metastatic. This is the main contraindication. There is no change. So of course, T4 tumor are contraindicated for surgery, and particularly minimal invasive surgery, and the other general contraindication, as we know. The minimal invasive surgery doesn't modify the principle of surgery. So we know that in case of esophageal cancer now, it's really recommended to start with neoadjuvant chemoradiation in stage 3 disease. This is the results of a cross trial, which clearly demonstrates that with chemoradiation before surgery, we can improve significantly the overall survival for the patient, both for the squamous carcinoma, but also for adenocarcinoma. And when the tumor is located in the esogastric junction, what is severe 2 tumor, it is recommended to start with neoadjuvant chemotherapy with a FLOT trial. So this is the main principle of the resection. If we want to perform an oncological resection or the resection, we need to perform a subtotal or total esophagectomy with a good lymphadenectomy, 2 field, abdominal and thoracic one. This is a different option for the thoracic lymphadenectomy. Is a standard with able to remove the lymph node located in the inferior and medial part of the mediastinum, or extend to the right or the left paratracheal lymph nodes. And at least it is recommended to obtain at least 23 lymph nodes. This is a Japanese classification which clearly demonstrates the different lymphadenectomy according to the level of the tumor into the esophagus, located in the inferior part, the middle part, or the superior part. So what about minimal invasive surgery? Minimal invasive esophagectomy started in the early 90s and was introduced by Di Paola from Brazil, which published a case of transhiatal total esophagectomy, and Cucchieri from UK, we published laparoscopic and thoracoscopic esophagectomy. So The first issue is minimal esophagectomy better than open esophagectomy? We can find in the literature more than 10 meta-analyses, but only one randomized trial. And all these meta-analyses conclude that minimal invasive approach is associated with significantly blood loss, with significantly shorter length of stay, and the postoperative morbidity and mortality is similar between open and minimal invasive surgery. And very important, the survival at 2 and 5 years is not different between open and minimal invasive surgery. More recently, 2 papers were published. The first one is a meta-analysis with a propensity score analysis, and this paper showed that the rate of fistula after minimal invasive surgery is significantly higher than in open surgery, which creates a doubt in the medical community. And the second paper is recently published in Annals, which collect more than 7,000 patients in each group, and the paper was dedicated for long-term survival. This paper recommend minimal invasive surgery because we can reduce the 5-year mortality by 18%. So it's in favor of minimal approach. The second question, do we have to perform transthoracic or transhiatal esophagectomy? Only one randomized trial in the literature published in 2007, which compared transhiatal and transthoracic esophagectomy. And as you can see, the transthoracic esophagectomy was associated with a better long-term survival, and particularly in the group of patients who have a small lymph node involvement, that is, involvement between 1 to 8 lymph nodes. Patient with no involvement has no difference between transhiatal and transthoracic. Patient with very huge involvements, no difference in survival. But in the group of 1 to 8, the transthoracic esophagectomy is associated with better survival. And this is a recent meta-analysis published in 2016, collecting adenocarcinoma of the distal esophagus and cordia. And once again, transthoracic esophagectomy is associated with a better overall survival and a better 5-year disease-free survival and a higher number of lymph node retrieves. Other issue, so it's a 2-field surgery with an abdominal and thoracic approach. So the first question, do we have to perform laparotomy or laparoscopy? Clearly, it's better to perform a laparoscopy. And this is a French trial called MIRO trial, which randomized patients operate with a laparoscopic and open thoracotomy, and patients with open laparotomy and open thoracotomy. This paper was published 2 times. The first one reported a significant reduction in the postoperative mortality and particularly in the postoperative pulmonary complication in favor of the laparoscopy, and the second publication for the survivor, no difference at 3 and 5 years between open and laparoscopy. So first conclusion, start with a laparoscopic abdominal surgery to perform the tube construction and the abdominal lymphadenectomy. So the next step, do we have to perform a thoracoscopy or a thoracotomy? And this is a time trial, published 4 times. And this trial randomized patient operate with an open approach, thoracotomy, laparotomy, cervicotomy, between patients operate with minimal invasive surgery, laparoscopy and thoracoscopy. And this paper once again concludes that pulmonary complication, particularly pulmonary infection, was significantly reduced with the thoracoscopic approach. And at 3 years, this is the primary endpoint of the paper, no difference between the 2 approaches. So we are waiting 2 other randomized trials underway now. This is a ROMO trial with 3 arms, a full open surgery, a full minimal invasive surgery, and hybrid procedures with laparoscopy and right thoracotomy. And the other paper from the Japanese group enrolled a patient since 2015. So now, if we decide to perform a thoracoscopic approach, do we have to place the patient in lateral position or a prone position? This is a retrospective analysis for 10 publications which compare lateral position and the prone position. And the prone position is associated with less pulmonary complication. Why? Because if you have tested this position, we have a very excellent operating field. So the gravity drop down the lung in the abdominal, in the thoracic cavity. So we do not have to retract the lung. We do not have to exclude the lung. And so we can reduce the postoperative pulmonary complication. And in this paper, the number of lymph nodes was significantly higher in the prone position. This is our experience published this year in surgical endoscopy, which compare thoracoscopic and thoracotomy approach. Once again, we demonstrate that the thoracoscopic approach was associated with less postoperative complication. Unfortunately, we also note a higher risk of fistula because the Achilles heel of this thoracoscopic approach is the anastomosis, is not now the resection of the tumor, is how to perform the anastomosis. And this is, so this is our policy, is to place the patient in prone position, and we have a very nice operating field to perform the resection of the tumor, a very nice lymphadenectomy in the inferior and middle part of the mediastinum. So there is another option, either the patient is placed in really prone position, and Kawakubo described a semi-prone position, or the patient is a little bit lifted up on the right side. This is to eventually allow the thoracotomic conversion. In our experience, we do not have any case of conversion after a prone position, but there is a few cases published in the literature. So the Achilles heel of this thoracoscopic approach now is how to perform the anastomosis. We have checked 3 options. This is the first one, is a side-to-side anastomosis. Very easy to perform, but we have a very big hole to close, so we use normally a V-lock to close. Second option is to perform a hand-sewn anastomosis, so it's an end-to-end anastomosis, the first posterior layer between the 2 staple lines, and then we open a little bit the esophagus and and we perform a gastrotomy and end-sewn anastomosis. So it's a little bit more challenging because we have to perform a manual anastomosis. And this is the last one we test, is a end-to-side mechanical circular anastomosis. So we can use the Orville system, transorally, and then the anvil is at the edge of the esophagus. Then this is a plasty, so you open a little bit the gastroplasty 5 centimeters at least from the edge of the gastroplasty, so you can pass the 25 diameter, and then we perform an end-to-side anastomosis. It remains to close the gastrotomy with 2 stitches, 2 layers of suture. And now our policy is to check the viability of the anastomosis and the vascularization of the anastomosis with endosine green. So this is a test. This is a lung, an anything by the ICG, and you can see the vascularization on the gastroplasty. So normally we have a nice anastomosis. Normally we have a good vascularization. So normally we can reduce the rate of fistula. So to conclude now, I consider the combination of laparoscopic and thoracoscopic esophagectomy is safe and should improve recovery of the patient. I recommend thoracoscopic in prone position to reduce the post-operative complication, and particularly pulmonary complication. We need to standardize the intrathoracic anastomosis, because I know many surgeons prefer to perform the anastomosis in the cervical area just to reduce the risk on intrathoracic anastomosis. I think it's not a good policy. And right now, the rate of oncologic resection is similar to those reported to open surgery. Thank you for your attention.